Hey everybody, this is Professor Butler. I'm going to be presenting your pre-work size for your infant, toddler, and preschooler growth and development. This is the lesson that has the most to talk about when it comes to growth and development because the ages of infants and toddlers, there's a lot going on. So I'm going to go pretty fast, but again, this is a video, so you're more than welcome to go back and, review this. Let me know if you have any questions, and then we'll do some things in class to kind of re-emphasize some points. But I'm not going to be able to go over everything in class, which is why I flipped the classroom so that you get some information up front, and then we go over some specific things while we're face to face in class. So let's go ahead and get started. So for the objectives are listed here, but they're also listed on Canvas. To start off, we're going to talk about the fact that this is one of the two rapid growth stages in development. The other one is adolescence, which we'll talk about next week. And this is also the time where children are mostly monitored very closely to make sure that they're meeting those developmental milestones. They'll have frequent screenings. Their doctor visits are 2 months, well, 1 month, a week. Let me get back. A week after they leave the hospital, then a month, 2 months, 4 months, 6 months, and 9 months, and then the wonderful yearly visit. Um, this is also where they receive most of the immunizations. And if we see something that is concerning, we can refer children to be in an early intervention program. One that you've probably heard of is Head Start. Children can actually have a qualifying diagnosis. There's a lot of developmental diagnosis as well as if they were in the NICU for an extended period of time, if they receive oxygen, if they were on a ventilator for a specific time, that would automatically put them in a category to receive early intervention program, early intervention therapies, so that they can catch up or not fall behind because of some of the things that were done to them or some of the things that they may be dealing with that would make them developmentally delayed. Daycare usually starts around 6 weeks, and the reason why I have that there is because this is the time period where they start to enter into society and get exposed to more of the viruses and communicable diseases. And as you can see, 6 weeks is pretty early. A lot of countries do not even fathom doing it until like around 6 months. But here in the United States, they can go back to, families can go back to work at 6 weeks and children can enter into daycare at that time. So that's pretty significant. Again, this is where delays are noticed. We monitor them very carefully. People who have been working with children for a very long time, like myself, we have an eye where we can see certain things, certain mannerisms, certain things that they should be doing depending on how old the child is. And if they aren't doing it, then we are going to start to investigate to see if this is something that's new or something expected, and what can we do to get this child on track? All right, next slide. I'm trying to get it to go. All right, so some key terms and some concepts that you do need to know as far as when it comes to growth and development. So growth is a physical quantitative measurement. It is looking at their size, looking at their weight. We're going to talk a little bit more about the type of measurements that we do for children as they grow. And then where development overall is this overarching term talking about their abilities. They are obviously going to start from a simple ability going into more complex. That also is kind of closely related to maturation. And so that is the ability to being able to function. So as they grow, they should be able to do more complex tasks. So I'm going to talk about something that they really don't monitor anymore, but that's like, let's talk about handwriting. So handwriting. So at first they're going to probably be doing scribble scrabbles, being able to grasp, being able to, do certain lines, circles, and so forth. But then they're going to start to get higher functioning where they should be able to write in a way that it's legible and then go into cursive writing, which is something that they don't teach them anymore. But then that's something we used to do to seem to be able to do cursive writing. Also goes from a physical standpoint, from a gross, if you think about gross motor skills, of being able to actually stand up, right, bear weight, being able to do, and then going into being able to stand on one foot, right? being able to go upstairs properly. And these are all the growth and development things that we look at, going from a very simple task all the way up to a more complex, mature functioning task. And so you probably also heard the word milestones. And so milestones means that basically, in general, at this age, they should be able to do this particular task. And so it's just a guideline, but it isn't something that we put kids in a box and say that you should be able to do X, Y, and Z at 6 months, right? You know, some children might do it at 7, some children might do it at 4 months. It just depends on the child, the resources, is there anything that might be hindering them, and so forth. So milestones are particularly just our way of saying, hey, this is technically, when this child should be doing it. So now let's talk a little bit about what we see in infants. You're more than welcome to read this, but some key points that I'm going to talk about is their weight gain. That's very, very important. Children, when they're born, let's just say it's an 8-pound baby, and they are always going to lose fluid. They're always going to lose weight after they're born. So they're usually not going to leave the hospital the weight that they were born, So, the child is born, they put them on the scale, they say this is what they weigh. But they are going to lose weight over the first week, well, first few days actually. And then what we look for at that first week visit is that they're eating and growing appropriately, that they go back up to that initial weight that they had when they were born. Okay. And that's because they lose amniotic fluid that was in their lungs. There's a lot, certain fat, they call brown fat, that actually is used to keep them warm initially until mom's milk comes in. There's a lot of factors that play into the weight loss initially, and it's completely normal. But what's important is that the child is gaining weight on a regular basis. And so we want to see a steady, increase in weight, and that we'll know because we're going to be measuring that. But if they're not doing that, then we have to investigate what could be the problem. There could be a metabolic problem. There could be that the child's not getting any enough nourishment. What are the things that, again, that we could do to support this family and this child so that they have adequate weight gain? Um, all right, and then you have some measurements as far as head circumference, some little key facts I have here. Let me get my cursor. Head circumference is about 70% of the adult size. How long they should be technically sleeping, because a child who isn't sleeping actually is burning more calories, which could be hindering their weight gain, but it also could be a signal that something else could be going on. Technically, they should triple their weight by 12 months, and their height and length should be doubled by a year. So these are kind of our rule of thumbs. These are things that we kind of look at and kind of measure to see where they are. All right. So now let's talk about some other things that we're monitoring as far as physical, because we're talking a lot of physical stuff right now. So those fontanelles, those soft spots that children have because their cranial sutures have not closed. And so it's really important to know when you would expect for them to close. So the posterior closes between 6 to 8 weeks, and then the anterior closes between 12 to 18 months. Make sure you know that. And head circumference. So you see the child in the picture, she's so cute. That the head circumference is what we're measuring, and that's exactly what we measure, and how we measure, excuse me. And the thing about head circumference is we want to make sure that we're having adequate brain growth, right? Or making sure that the cranium is not abnormally small or abnormally too large, okay? Um, so if it's getting too large, it could be a signal that there could be some increase in fluid on the brain, which is called hydrocephalus, which we'll talk about later on down the line. But that's a neurological disorder that we do not want to happen at all. And also, if it's not growing adequately, that can mean that the child's brain is abnormally small, and that could lead to later on down the line that they could have intellectual issues. All right, and then we have our vital signs, technically where they range, and then their respiratory rate, which I know we've already talked about. And then here's again where they typically would sleep. Obviously, the younger a child is, the more they're going to sleep. As they get older, they should not be needing as many naps, and they should not be needing as much sleep. as you will see as we go through the ages and stages. Now let's talk about physically what we should see from an output standpoint. So stool output is obviously the first one is meconium. So when they're first born, they should pass the first stool, which is a meconium, which is a really black, thick, tarry stool within the first 24 hours. If there is a delay passage of meconium, that could signal some conditions that we have to further investigate. So we always are monitoring to make sure that the child has had a meconium stool before they leave the hospital. Some children actually can pass their meconium before they're born, and that could be a delivery emergency. All right, so breastfed babies, as I see here, as I have here, is that yellow seedy stools that you typically would see. They usually have lots of frequent stools, and that's normally what you see with breastfed babies. For formula fed babies, you'll see that pale yelling, what we call transitioning stools. It's because they're taking formula, and so their body is they're not getting that breastfed milk, which is not as dense. And you can see all different colors and transition stools. And it also is going to be a little bit more thicker and more pasty, more solidy than the breastfed babies. Now, output. Now, this is important. This is going to be something we're going to practice in class, and it's going to be it's how do you calculate output. So obviously, in this age, they're in diapers. So we're going to have to weigh the diapers to figure out how much is actually accounted for urine and stool. And then we would then divide that by their weight and divide that by the hour count. And again, I'll go over that. But the key things that you want to know and you want to remember right now is that we are looking at output to be no less than 1 milliliter per kilogram per hour. Okay. So when I go over in class, it'll make sense. It's a very simple calculation. And if a child is less than 1 milliliter per kilogram per hour, that's a sign that the child could be a little bit dehydrated. And what we tell families is that a rule of thumb is if your child is giving you 6 to 8 wet diapers a day, that is a sign that they are nicely hydrated and that they're not dehydrated. But if it starts to drop below that, then you probably want to give us a call or bump up their fluids as long as it's nutritional and it's not substituting like water for formula or breast milk. All right. So key point here you need to remember is that 1 milliliter per kilogram per hour is our measurement as far as, if a child is dehydrated or not. And do I need to call the doctor because, my child is zero point 0.6 milliliters per kilogram per hour, and that's a problem. And yes, there is a number for if it's like 4 or more milliliters per kilogram per hour, then they could be diuresing, and that could be a sign of a condition that is making them diurese, making them pee a lot. And so because of that, they can actually become dehydrated because we need to actually fix that condition or do some interventions to prevent them from losing so much fluid and becoming dehydrated because of that. So the next thing we're going to talk about are some of the infant vision and hearing. Some of the key things that we should see is that at 1 month, they should have that startle reflex should start to wane. They initially have that startle reflex when they're born. We actually test them for that from a neurological standpoint. And they will have that universal hearing test. So that's called the Bears test. There's another name for it as well before they leave the hospital. And that's just making sure that we're not discharging a child who is deaf. Okay, so it is a universal hearing test. It's in standard. They do it. It's automatically. And if there are any problems with that Bears test, then they would let the family know. At 3 months, they should turn their head to sound. 8 months, they should respond to their name. Vision, as you see some key points here for vision, what we typically would see from 1, 3, 5, and 6 months or greater. So for vision, they should be able to follow objects. So basically what you would do, if I had an object in my hand, they'll just kind of look at it and you want to kind of move it to see if they just kind of look at, just kind of turn their head just a little bit to see it. And that's at 1 month. So they should just be looking, or they could be looking at your face and then smile or cry. when they are looking at you because they don't know who you are and I want to go back to mom or dad. At 3 months, they should be really engaging with their hands or with an object that they are kind of grasping onto while laying on their back. And then at 6 months, is when they see colors. And then at 6 months or greater, they should cross the midline. So when I say cross the midline, is that if you are holding something and you now want to move it across to the left and to the right, they should be crossing all the way over to the other side, all the way over to the other side. If a child stops midline, that is a sign of developmental delay, and we need to kind of look a little bit further and see what are some circumstances that may have happened that could have made this child developmental delayed, and again, get some resources for them. Um, so let's now talk about the different vision and we'll talk about the vision test. So the formal vision screening starts at age 3, but I'm going to talk about it here because it kind of encompasses all of what we're talking about here because we do have toddlers. It's important for you to know some of the abnormalities that can happen with a child, and this is one of the reasons why we do all types of vision assessments. So, when we go to the doctor, they tell us to, read all the letters and so forth. But children don't sometimes know their letters, right? So we have different charts for children. And we also need to look at their ears and look at how they're aligned. All of these things can point to different things. So let me start from the top. So from the inspection, we also just want to take a just good look at the ear. All right. We want to make sure that we don't have any tags. And these are like abnormal skin growths on like the pinna. We want to look at the internal and the external structures. And we want to also make sure that it is midline to the eye. So I have my glasses on, but you want to make sure that the ears are not lower than the slants of your eyes. So if it is, that is a sign of some type of syndromes that child needs to possibly be worked up on. So if there is a slant where their ear, we call them low set ears, then that means that they could possibly have some sort of syndrome. All right. So that's what we look for that. We also look and see if they, obviously abnormally dry. We will do a cover test. We will check their pupils. Obviously, we want to check their pupils are equal and reactive to light. And then we also want to check and see alignment. So this is a big one. So we want to make sure that they're aligned equally. And doing that, we can do the cover test, but the most popular test that we do, especially for this age, is to do a Hirschberg's test. Okay, so Hirschberg's test, I have two asterisks by there, and that means that it's important. And the Hirschberg's test basically is you just shine a light. So you stand a little bit away from the child, you shine your pen light, and you just tell them to look at the light. That's it. And what you're looking for is that the light is shining equally in both of their pupils. If it is not, and if it is one is like over to the left and the other one is in the middle, then that tells us that there is an alignment issue and they need to be evaluated by ophthalmologist to get it right. All right. So visual acuity. Okay. So obviously with our infants, we're just going to look at the pupils, take a look at the ears, doing an inspection and do a Hirschberg's test, right? And also see if they can track. As they get older, we can start doing some of the visual acuity. So the HTOV and the tumbling E, these two right here are alternates, right? So if a child is able to tell us the OTHV, then we can use the HTOV chart. If the child is unable, then we can use the tumbling E. The tumbling E chart, they basically would say, which way is the E pointing? Is it pointing this way? Is it pointing down? Is it pointing this way? So they don't need to know their letters. They just need to be able to point and tell us which way the E is pointing. Okay. And so those are our alternative charts for children who cannot use the traditional chart, which you see there to the right, which is the Snelling chart, which is what we use. Okay. All right. Red reflex and peripheral vision also is checked as well if they can cooperate. And then we do have some children who are colorblind, and until we actually inspect and use like special devices to see and put on special glasses, then we wouldn't really know. But there are some children who are colorblind and they have to have special glasses. So there is a video down here at the bottom that you can click on. It's totally optional to do if you want to see a, pediatric eye exam. All right, so here are some of the vision impairments. We'll start off with some of the causes. Gonorrhea, chlamydia infection. If a mom has an STD when she is delivering and may not know. Also, syphilis or some other condition. As the child goes to the vaginal canal, if it's a spontaneous vaginal delivery, the child's going to get that infection, okay? Which is why we put antibiotic ointment on their eyes right after they're born. Okay. So anybody who's knows about the process or seen a birthing process, you would know that we immediately put antibiotic ointment on their eyes to prevent any type of infection. There are also some other causes like retinopathy of prematurity. Now that is for a child who was born premature and they if so this has to do with oxygen, and you're going to hear me talk about this again when we get in cardiovascular. We'll talk a little bit about our NICU babies who are receiving a lot of oxygen, but oxygen has a lot of factors to it. You can't just give oxygen. It is a drug and it has some side effects, and so these when oxygen is broken down, there are some substances that deposit in the brain, the liver, all type of places, and one of the main places that they do deposit is in the eyes. And so a child who's on prolonged oxygen on a ventilator for a very long time, they can develop retinopathy of prematurity because of the toxic side effects of being on oxygen so long. So we'll talk a little bit more about that. And you probably remember when we get to cardio, how I say it's very careful. There's a lot of reasons why you have to be careful about oxygen, but this is one of the reasons why you definitely want to be careful about oxygen. Also, kids do stick things in their eyes. To be honest with you, we can have some trauma to the eyes. We can have some postnatal infections, like, the eye infections, and just simply from some drainage, some ear infections can also cause some infections as well. Excuse me. All right. So what I want you to really, so these are all these causes, right? But then think about all these things that they could be born with. And so stigmatisms, nystagmus, amblyopia, strabismus, these are common terms that you do need to know about because these are some of the things that we want to look for because if a child has any one of these things, they we have ways that we can fix it so that their vision isn't impaired as they get older. It's very harder to fix as somebody gets older. It's easier to fix when they're younger. So, looking for these type of conditions is very important. Just a reminder up here about visual impairment, what is considered legally blind. And then when you're caring for a child who unfortunately might have a visual impairment, it's important that when they're in there, when you're care, you kind of think about these things that are listed here, like you want to orient them to the surroundings because a hospital is a strange environment. And we want to make it safe because they're higher potential of harming themselves because they're just not familiar with the placement of the bed or where things are. And so we have to put safety measures in place to make sure that they don't hurt themselves. But at the same time, you always want to encourage them to have a really good amount of independence. So we want to do as much as we can to support them, but also keep them safe. There needs to be consistency of team members. I think that's very important. That's called primary nursing. And there are some things that we can do to reassure somebody who is visually impaired. I love to do the tapping method. The tapping method is kind of a universal thing. I always like to share the story of a child that I recently took care of with a student. I happened to be with them and he was a biter, so I didn't want my student to get bitten, and I didn't want to get bitten. And so we had to do some procedures with him. And we were fully warned to be very careful because this child will automatically bite you. And it's just more of a defensive. He wasn't trying to hurt us per se, personally. It was like he was scared. He lost his mom. He was with his dad. His dad was grieving, and it was just a lot going on. And so when we went in to take care of the child, the tapping method. And the tapping method isn't this where you're doing this on somebody's face. You probably have seen something like that. Tapping is something you can tap their shoulder, but usually you want to tap next to them, like a chair that they're sitting on. And in this case, I was tapping the bed. That is a very calming method to use for somebody who has some type of sensory loss, because it's kind of a way for us to say, I'm here, I'm with you, you're safe. And so I just started to tap the bed. I started to tap the bed. I kind of put my arms around him and I just tapped. And I think his mom used to do that a lot. And he just smiled from ear to ear. So tapping is a method you can use. And trust me, if there is a child who's been visually impaired for a very long time, they will understand the tapping. Playing and socialization is very important. We do not want to isolate children who have sensory loss or vision impairment. It helps them build their level of dependence, and then Braille and all these other adaptive stuff. We want to advocate and make sure that we get that stuff in place so that they can communicate with us in the ways that they know how to. All right, so here's some pictures. So this, you see this alignment, see where this eye is good and this eye is not, is more deviated um, adductively. This one, okay, so you see the light. All right, so you see, this is a normal Hirschberg test. This one, yeah, I don't even, oh, here's a white light. So see how it's off to the, I think that's, well, if you're looking at it, it's to the right, but the child's left. And then this one is center, but this one is not. All right. So these are signs that we have an alignment issue. All right, so now let's talk about another sensory issue, which is our hearing. And so again, you want to check. I've just realized I was talking about the ear the last time. I just mixed them all up, don't I? But I already went over about the alignment of the pinna, looking for any tags, and so forth. You can, some nurses are trained to actually look. We're going to talk about otitis medius in the respiratory lesson, ear infections. And so we'll talk more about that, about what it looks like. But you can do an ear, sorry, you can do an inner ear inspection if you're properly trained. And if you are properly trained, you need to know how to hold the child's ear based on their age. And so if you're less than 3 years old, you need to pull the pinna down and back. And if they are greater than 3 years old, you need to pull it up and, yeah, up and back. Okay. And that's just so that you can visualize really well. Of the inner ear. Okay. Now, here's the Bears test that I mentioned before on the previous slides, in the earlier slides. And so here's a child getting a Bears test. And then here's showing how the ears should line up with the eyes. And then here's a picture of a tag if you've never seen a tag before. Obviously, we can have different types of hearing loss. We can have conductive hearing loss, which is affects the middle ear. It's usually treated with if it's an infection that's causing it, you could obviously fix that. And sometimes they might have to have some hearing aids. It could be central neural hearing loss, which is auditory nerve or inner ear, where they have to usually get an implant. And then it could be a mix of some. All right. Again, there are some things that we can do to help them. And again, tapping's not here, but tapping will help. Um, and then we also want to do a lot of these different things. And I'm not good at lip reading, so I automatically go get a whiteboard and hopefully they can do that. They can write. Um, oh, here's tapping down here. I do have tapping. But any child who has a lot of ear infections or maybe some other conditions. Audiology will always be screening them initially at every appointment just to make sure they're not losing their hearing, that there's no progression, and so forth. But when we're caring for them, we want to facilitate all these different things that are listed here. Very straightforward. Listen to the parents, take the cues from the parents, and then go from there. Again, keeping them safe is very, very important. And making sure that it has you have a team that usually is the main nurses that are caring for them. That's actually one of the best things that could be put in place if possible. So screening for sensory, I've kind of told you a little bit about it, that it is remember I told you the Bears is a universal. That's that newborn hearing test. Identification of hearing loss before 3 months. We can put interventions in place no later than 6 months of life. This really is key to make sure that they have everything in place to support them. Premature neonates are more at risk because of a lot of things. One, it could be, oxygen, it could be medication. Specifically for hearing, it's antibiotics, if they had antibiotics in their hospital stay. Um, Another big one being that I used to be a NICU nurse as well, is that people don't realize that their hearing isn't formulated well. So people who are very loud in the NICU, or one of the things I used to get on nurses about is is writing or charting on their isolate. Okay. That sounds like a freight train to their ears. And so we're damaging their hearing because we're not mindful of the level of noise. So if you've ever been in the NICU, you notice how they have the lights down. They have this, it's really like quiet. Like you're like, I could never work here because it is so quiet and so it put me to sleep. Well, it's like that for a reason. And mostly it's because of our patients, because they are still developing. They're not in utero. They're out in this world that actually is doing damage to their sensory system. All right. So if hearing loss found early, or not found, they could miss language milestones because in order to talk, you have to be able to hear. They can have a lack of response to noises and danger. Older children will probably just use gestures and be very, very withdrawn and shy and have behavioral problems. Vision impairment, again, it could be related to a lot of different things. It also could be generic, which I didn't have listed before. We have other interventions. That early interventions, again, is to put in place to help them promote attachment, really big in the early stages. And when I say attachment, attachment to the family. We will initiate safety protocols. I already talked about that. And behavioral and cognitive therapy will usually sometimes, depending on the child's temperament and ability to adapt, will always be in play. And communication development and socialization therapy is always very important to put in play for these children, and not only them but also the family, because the family has to learn all of these adaptive ways of communicating and interacting, excuse me, with a child with a sensory impairment. All right, now we're jumping into toddlers. So I just talked a lot about infant. Now we're going to switch to toddler and preschool growth and development. So this is going to talk about their physical things. So again, we have here listed, kind of what they should be growing and gaining weight. And then we have what their height should be. At 12 months, their height increases like 3 inches a year. So as you can see, this is something that is much slower than the infant. Head circumference equals chest circumference. Let's see here, 12 to 18 months, their anterior fontanelle closes, which we already talked about that. And at 2 years, they should be sleeping just 11 to 12 hours of sleep in the after and maybe an afternoon nap. Okay. Some of the milestones, some of that, remember, simple to complex. So for complex, we should see them beginning to dress themselves, work with objects like certain cups, sippy cups, and maybe progress a little bit to cups without the sippy. potty trained, which we'll talk about a little bit later on, and they can use language and gestures to communicate. All right. And let's see, the next slide, we'll talk about gross motor development. So for gross motor development, is typically what we will see. We'll have, let me look at me, make sure I get this right. So sometimes I start talking based on what I've seen and I want to align it with your book. All right, so gross motor. Before I do that, let's talk about what gross motor development is. So gross motor development is looking at the posture and the head balance, the sitting and the creeping, the standing and the walking. And I like to describe it as the large muscles. So these are our thighs, our legs, our abdomen, things that make us stand erect, things that allow us to ambulate. Those big, large muscles are the muscles that we're talking about when it comes to gross motor development. Later on, we're going to be talking about fine motor development. So we're going to be contrasting the two. So gross motor development here, this picture here. So A is at 1 month. And so this is the child who first is going to lift their head. Now, one of the things I talked about before is the order in which growth happens. And so that's cephalocaudal and proximal distal. And so cephalocaudal means that it's from head to toe, right? So the first thing here is this child is learning to control their head. All right. And so that's what we typically would see. So they control their head, then they control their torso, then they control their hip area, and then they can kind of straddle, and then they can do it on their own. Then they start getting up on their knees. Then they start crawling maybe, and then they start getting up and they're going. Okay. So that is that cephalocaudal. So the first thing is that head control. B is 4 months. And now the child is lifting up. So we got the upper torso. So you can see they're up on their hands and they're looking forward and they've got really good control of their head. And then C is 6 months where they can still do that. But now they really got control of their torso because they can pivot and look behind them. So now they can rotate. All right. Another picture out here is 3 to 4 months, and I like to show this talk about some things. So let's talk about the one at the top. The one at the top is yes, the one at the top, making sure I have it right, is newborn, obviously, right? So no head control at all. But what I would like to also show you is that what we're looking for when we do that is that head lag back. So one, it tells us yes, that they don't have the head control, and that's totally appropriate for a newborn. The lag will disappear when pulling to a sitting position by 3 to 4 months, which is B down here. And that's good, but they don't have that really good, strong abdomen control. And then by 6 months, you see they're really erect here. They're bored. The back is like a board. All right. And they really are tightening up that abdomen and they're helping sit themselves up. What I want to say is that if you see what you see here in 5 to 6 in the beginning stages of newborn, that means we have a child who possibly was exposed to something in utero. And it could be an opioid, it could be some type of substance, some type of drug, right? It could be a prescription drug. Regardless, they're going through withdrawal. Okay. So neonatal absence syndrome is a syndrome that causes a child to go through withdrawal for whatever reason, and they will look like C at age A. So that's one of the signs that if a child is stiff like this when you're doing that test, that's a sign that they have been exposed to something in utero. All right. So let's go to the next picture, which shows you again kind of what I was already talking about. Top right, we have 2 to 3 months of age, rounded back, knee support sitting. All right. And then 6 months, we have a tripod position where they're up, but they're kind of holding themselves up a little bit with their forearms. Um, so they still need a little support. One little pushover, that child is going to go tumbling over to the right or to the left. And the bottom image, even though they're sitting in a boppy, um, this child clearly has really good control. Probably could lean forward and go for this toy here and not have any balancing issues. All right. All right. Let's see here. More pictures. I love pictures here because I think it really shows because you are going to be tested to make sure that you understand what is expected as far as from a physical growth and development. This picture up here, this AB is called parachuting. It's a reflex. So you can put a child and then let them go. And if they lean forward, a reflex, this you have the startle reflex, right? But this reflex is called parachute reflex, where their arms are automatically going to go out to kind of support them to prevent them from hitting their head. But here, this talks about this is a good one to show you that the round back. Okay, so this child here has a round back. And so this is C. Um, and they can sit upright. Well, they can't sit upright, but they can sit up. But if that person lets go, they're going to go falling back. This one again is a kind of an altered tripod. And then this one here it's not. And then what I want you to look at, you see that wide gate here where this is a V and then this child an E. It's not a V, it's more balanced and it's more straight. And that's because they have more gross motor development and they can sit more without having that wide base to support them. And you're going to see a great picture of that in a second. All right. Again, I think this is the last of almost. We got one more slide. So then here we have again showing you about weight bearing. So obviously newborns can't, but what they're also showing you here is that walking reflex is another reflex that we check. And so if you just have the child and you do this, their feet will go like this. They're not bearing any weight, but it's called the walking reflex. At 6 months, they should bear full weight with some support, standing, and then 9 months they may crawl, or the book calls it creeping sometimes. And then at 12 months, they should definitely be cruising. That means they're holding on to furniture and things to get around, and they are just about to get to the point where they are going to let go and then they're going to take off. All right. And so this happens, cruising usually happens right before they start walking independently. And then one of the things that I want to mention is that children who might have some congenital issues like club foot or could be have bow legs or blouse disease or have a vitamin D deficiency, rickets, they might have some delays in this area. So we see children who might have some delays in growth and development and gross motor development. It could be because they have one of the conditions that I'm talking about. All right. So identification and treatment really should be done by 2 years of age. I think before a year, to be honest. All right. So here is a chart. So this chart really shows you some of the things. This is going to be important for your test because you want to have the terminology down. So when I'm testing, I'm going to be testing where I'm going to be pulling out keywords. And this is what you need to know. All right. So I'm not necessarily going to show you pictures. I'm going to use words, words that I've used to describe things and also words that you see here in this chart. So knowing that from 12 to 18 months, these are some of the things: 18 to 2, 2 to 3, 3 to 4, and 5. Again, going from simple to complex. And then let me see here. I'm going to show you a picture. So this is the picture I wanted to show you about the wide stance. So here, these younger children, these top pictures, see that wide stance, that gait? They need that wide base in order to be able to balance themselves. Then as they get older, that base gets narrower, as you can see, where they can throw a ball, they can hop and skip on one foot. That's what we're looking for. So when we ask, hey, how old is this child? Oh, they're 3. Oh, okay. All right. I'm looking at their legs. I'm looking at their movements. I'm also doing some other things we'll talk about, like language and so forth. All right, so let's go into fine motor development. And with fine motor development, we are going to talk about different type of grasp. All right. So the palmar grasp, which is for our infants, that's going to be the first one. You put something in their hand, they're going to use their whole hand in order to for their fine motor development. That's it. It's very simple. That's what they do. It's mostly their hands are usually mostly closed initially. So like when you're washing and they're getting a bath, you usually have to pry open their fist. And then they end up going over into what we call pincher grass. So pincher grass usually happens between 8 and 9. And then we start to get into our crude or inferior pincher grass, developing pincher grass, and then last would be our neat and fine grass, like picking up a Cheerio. What is this showing? Fine motor skills, little small muscles in our fingers, right? We also have small muscles in our toes too. But what we're assessing the fingers, the fine motor skills. So that's for our infants. So make sure you understand palmar grass, pincher grass. Then we have our crude, developing pincher, and then our neat and fine. That's the order that they go in. But let's look a little bit further. So with our toddlers now, what we're looking for is how are they drawing? So this is what we usually would do when we go out to assist. We give them crowns and we give them paper. And we tell them to draw me a picture. All right. We're looking at a couple things. We're looking at how are they holding the crown or the whatever marker you give them. And we're looking at are they doing scribble scrabble? Are they looking at clear, fine lines? Are they fully drawing me a human picture? Right? So looking at this diagram you see for early toddler, we see like 1 or 1.5. This is what you're gonna get. This is what you're going to get, right? Then you're going to start to get some diagrams and some combinations with circles plus crosses or X's, straight lines. And then we're going to get a little bit more complex. As you can see, people have hair, they have fingers, they have toes, they have feet, you have houses and dogs and stuff like that. So this is obviously later on going into obviously our preschool years, but this is our late toddler, and then this is our early toddler. Put a star on this slide. All right, let me see. And then here's a chart for the words to describe the fine motor development. And then here you'll have, from 12 to 18 months, the same breakdown as you saw before, but you're going from simple to complex types of movements and capabilities. All right, I think what I'm going to do is I'm going to stop right here. I'm going to stop at language. I think we can do the rest in class. And we also have some conditions that we need to talk about as well. So if you have any questions about anything, definitely let me know. When we're in class, I can go over them a little bit more, but that's about it for your pre-work for this one. I will see you in class.